Hello, I'm Mary Ito, and welcome to the CRAM podcast. CRAM is an acronym for Communicating Research and More, which is what we try to do with this podcast. A lot of exciting research and groundbreaking ideas never reach the public, but they have the potential to change the way we think and act. Many people dream about winning the lottery, and that if they win, it would be the best thing that could happen to them. What they don't realize, though, is that they've already hit the jackpot of life. These are people who were born in a developed country with affordable health care. They have a good education and job and loved ones who support them. That's what eminent researchers like John Frank believe. He's tried to answer and act upon the question, what really creates better health in people? John is the former director of the Scottish Collaboration for Public Health Research and Policy and a professor emeritus with the University of Edinburgh and the University of Toronto. Hello, John.
Hello, Mary. Nice to be with you.
Oh, well, thanks for joining us. You are going on, I guess, nearly half a century of work in public health. How did you become interested in this area in the first place?
Well, I didn't start out in public health. I started out as a general practitioner, a physician. I worked in a few settings in Canada, including some student electives in the far north, and learned a lot in those settings. But in the mid-'70s, my wife and I decided to go and volunteer with CUSO, Canadian University Service Overseas, and work in Tanzania for 2.5 years. And I was a general medical officer. She taught African literature and English in a town about 500 miles from the capital, but in the corner of the southwest in the mountains of southwest Tanzania, Mbeya. Now, in that kind of environment, it was pretty primitive medicine because the hospital was quite, let's just say, not well maintained. And we used to say we had a patient in the bed, patient on the floor, patient in the bed, patient on the floor. The whole hospital was like that. So you had to kneel down a lot, examine the patients and talk to them. But anyway, I taught African students, my Tanzanian students, 3 classes of them, and to do a job called a medical assistant job, which is they have 3 years after high school, no degree, in order to become adept at seeing a few hundred outpatients a day and dealing with them in 3 minutes each. They might have 10 drugs at their disposal and virtually no lab tests. So that's very stripped down medicine. It teaches you a lot. It focuses the mind. And as I left, I remember driving away from town and looking back and saying to my wife, oh, I see the outpatient lineup still has 300 people in it by 9 a.m. And my students would be looking at those people as their patients. And I thought, next time I do anything in the rest of the world, I'm going to learn how to prevent those people from becoming ill. Because you see, we would give them some drug, an anti-malarial, an anti-worming agent, whatever. And we give them something that would help them with the immediate episode. Then we'd send them back to the same village with the same inadequate housing, inadequate nutrition, no transport for women in labor or people who suffered an accident, and lots of disease vectors like malaria for mosquitoes and a little thing in the water. So if you go in the water, you get schistosomiasis and it wipes out your bladder and finally your kidneys, and maybe it gets into your liver. That's the kind of environment they lived in. And if you just kept doing that, that's revolving door medicine. So I went off and trained in public health at the London School of Hygiene and Tropical Medicine with the support of a scholarship from the Canadian International Development Agency. So I'm very grateful for that.
You know, in the introduction, I mentioned the jackpot of life, and I guess that's better known as the social determinants of health. Tell us, what are they? And, how long have they been with us?
Well, much of the understanding of the social determinants of health goes back more than 175 years. So there was a very famous German pathologist. We would call him a pathologist now, but he was a sort of an academic doctor. But he was a social activist. His name was Rudolf Virchow. And Virchow was asked by the good burghers of his German city, who were dependent upon coal from a part of what's now Poland in the south called Silesia, to go and investigate why they weren't getting their usual coal supplies, because they'd heard rumors there was a terrible outbreak of a disease called typhus. Now, typhus is a disease carried by that form of lice. And the lice mean, if there's lice at that level in the community, it means no one can bathe, no one can wash. There's no adequate supply of water. And so before he left, he knew he'd be facing very poor mining communities. And he went and he did a very thorough investigation. And at the end of it, he said, well, people's lives have an unacceptable quality there. They're so poorly paid. They're down in the mine. They get lung disease. They don't have adequate nutrition. And they live in crowded housing, where there's no running water. And he said, it's no wonder they're dying like flies. So he wrote, that medicine is but politics writ large. I'm paraphrasing. And so he's one of the first people to really bring into, sharp relief the importance of non-medical care factors. And medical care at that time was almost useless in terms of curing anything. You know, they certainly couldn't cure this disease, typhus. And they didn't even know precisely how it was caused. But that was true for most diseases. The little black bag of the doctor contained very little, a bit of opium, a bit of foxglove for your heart, and he could kill you easily with those. So it was really much later that we began to think of medical care as very powerful. And we can come back to that. But the key thing is the conditions under which we grow up, live and work and end our lives. And those conditions are around, for most of the people who live around the world today, are still far from optimal. So Canadians have a very good time of it. But amongst Canadians, the people who are systematically less healthy for almost any health outcome, any disease you want to name, are the poorest and least educated. And that's true in most of the world. And it's particularly true here in Scotland.
There are what, about 14 social determinants of health? I mean, there are probably more, but sort of main ones?
I don't usually count them because you start to get into overlapping categories. But
so what?
Yeah,
so sort of main areas.
Say there are five. I say there are five.
Oh, five. Okay.
Yeah. Okay. So when I teach this, I say, look, the first one is it helps to have medical care, access to good medical care, high quality. It's not as important as people think, but it's still important, especially to relieve suffering and reduce disability. So, for example, among the elderly, we have procedures that are really good at improving severe disability, like NIP, knee and hip. Yeah, right. NIP, knee and hip. You thought I was going to say nip and tuck plastic surgery. No, knee and hip, osteoarthritis, joint replacement, and cataract surgery. Fabulous procedures, massively improve people's quality of life. Do they live longer? Probably not. But that's not what medicine's all about. It's about quality of life, relieving suffering. And we have many other treatments now, which weren't there when I began to practice in 1974, as an intern at least, that are effective for, conditions that were previously untreatable. We have dozens and dozens of conditions for which that's true. And that's thanks to modern medical research. So there's a lot to be grateful for. I don't want to say that first, if you like, principle of determinants of health, which is that medical care is often too little, too late, that's increasingly true. It's actually decreasingly true as we develop more and more treatments that are effective for major public health challenges. So I'll give you one more example of that, because I don't want people to think I'm ranting about the medicine of the past. So on Friday, I'm going to South Africa for collaborative work with colleagues at the University of Cape Town. And South Africa has done better than almost any other African country. Mind you, it's much wealthier and has much better infrastructure, to fight the three huge infectious disease scourges of that and many other African populations, malaria, TB, and HIV. And the first one was mostly about changing people's exposure to mosquitoes through land management, draining swamps, and initially, when it was still possible to do so, spraying against mosquitoes. Now they have only a tiny part of the country where mosquitoes still carry malaria in the far northeast corner. But for the case of TB, for which no drug treatments were effective until almost the middle of the last century, 1950, and HIV, for which no treatments were useful, no drugs were useful until the mid-1990s, and they took another decade or more to get into African healthcare systems because of their price at the beginning. Those things are life-changing, and they not only save lives, but they massively reduced deaths in younger people, really quite young people in their 20s and 30s. And so those are examples of life-changing treatments, which, if funded by the Global Fund, for example, across the poor countries of the world, so that people can get them for free, which needs to be the case because those people don't have any funds to pay for those drugs. That is life-changing, and it changes population health status. So I don't want anybody to think I'm unaware of that, because I did train in tropical medicine and community health for developing countries.
So that first category has definitely evolved.
It's shifted in a good way,
okay, it's shifted.
towards having more impact. The second determinant of health is not one you have much say over. It's whether you're born into a society which confers on you opportunities according to your gifts by having an equitable and effective education system that gives you the wherewithal to pursue the work of your choice and be paid adequately for it. So the second part is about the economy. Is the economy functioning at a level that will train people up and then pay them for work that's needed by the society? And this is not something you pick, right? You're born into a society. You don't pick your parents. But if you were to pick one thing, I'd pick your parents. Because that's going to make a huge difference, because within any given society, we have people on the wrong side of the tracks who aren't doing well, and people on the right side of the tracks who are doing fabulously, sometimes maybe more than they deserve because of the structure of how people make money. A lot of money is made now.
But you would pick the one thing that we really cannot ever control. I mean,
yeah, that's right. But it does help if you have parents who encourage you. This is well before you start school formally. As a good example is, and I'll be coming back to this later when we talk about early life, is a big factor in your success in school is, can you communicate? And one of the big determinants of that is, did your parents talk to you and listen to you from the really infancy? You know, the difference between poor children's and wealthier children's, mostly related to parental education level. The difference between those children's vocabularies at even just 2 or 3 years of age is gigantic. It's been documented by child development experts in more than one study. And if all you ever knew were children who were from the same large family, and all the children didn't speak particularly articulately until they, maybe ever, but they certainly weren't using full sentences in a good way at age 3 or 4, then you don't know that that's absolutely normal in families where there's a great deal of communication and parents are articulate, but also they engage the child in conversation all the time and tell stories, read bedtime stories, all these things, So those things are determinants of how you do in school, and how you do in school is gigantically determining of how you do in your career. It's possible to work your way up from a primary school only education, or maybe secondary school only nowadays, but it's the exception, not the rule. Okay, so we've covered 2. And the third one is the social class you're born into, which is why I said you choose your parents. So in Scotland, we have a system whereby, at least in Edinburgh, the capital city where I live, a surprisingly large fraction of parents pay for private primary and secondary schooling because they're pretty sure quality's better. And one of the reasons the quality is better is that the schools don't have any poor kids in them. And so it begets itself. It's a circular problem. It's gone on for probably centuries. And we have very fine private schools here, and we have public schools struggling to do their best with limited resources in often communities where, as I said earlier, the parents aren't particularly supportive of children getting very far in school because the parents never did. And so, we have a 2-tiered system of education. And so if I took you on a tour of the local housing estate and we popped into the local pub down there, which, by the way, I wouldn't normally go to because it's maybe not so safe for a guy who looks like me and talks like me, the local pub would be full of people who didn't get very far in school, and they've kind of made their peace with it. They're out for a Friday night, a Saturday night of drinks with their buddies. But if I took you to the high-end part of the city where people live in fabulous 17th century flats with 16 feet high ceilings and beautiful cornices and fabulous furniture and art on the walls, you'd say, well, these are some of the most sophisticated people in the world. And you'd be right. So this is all within one city. And they don't even go to the same stores. They don't actually travel on the buses together because the wealthy people drive and the poor people take the bus. And on we go. They don't have the same places to go for entertainment. They don't have the same interests. It goes on and on. So that is why Scotland has the steepest inequalities in health, because they are a consequence of having steep inequalities in the socioeconomics of life. Right?
So then these factors about where you live, do you have an income? Do you have education? Do you have a good job? Are you supported by people who love you, right? Those have become prominent in determining health outcomes, right, for people. How pervasive has that thinking been? How influential are the social determinants of health in setting public policy and influencing people who can make those decisions?
Well, there's a good and a bad to that. The good is that Canadians had a major role in writing up these ideas and demonstrating that there was plenty of evidence to back them, starting with the Canadian Institute of Advanced Research, nothing to do with the funding agency, Canadian Institute of Health Research today, led by a polymath Toronto professor, Dr. Fraser Mustard, who was a mentor for me. And Fraser set up not just a program to look at the determinants of health called the Population Health Program in the mid-1980s, of which I was privileged to be a junior member at that time. I was a very junior professor. But he set up another 9 programs around topics that he thought universities were not exploring very efficiently, things like cosmology, superconductivity, evolutionary biology, and so forth. At any rate, the 24 members of that program, who were mostly Canadian, but represented a huge variety of interests, from cultural anthropology, genetics, health economics, political science applied to health policy, nutrition, all of these people, most of them not physicians like me, not epidemiologists like me. Those people wrote a book called Why Are Some People Healthy and Others Not, published in 1994. And that book has been translated into many, many languages and has been read widely. And it lays a lot of this out, but it acknowledges that the ideas are not particularly new, that they'd been around for a long time. Now, the good is that was done. The bad is that in the ensuing, 37 years, we haven't had as much translation of those ideas into health policy as we might have hoped. We still have, I think, an excessive reliance, and certainly in the public eye, on medical care once you're sick, that we still think that's going to make the difference. And
why is that? Why do I think the public, I think the perception is that medical care is the be all and end all, and the better our technology advances, the better the better off we are in healthcare.
Well, most people don't realize that about 80 or 90% of the illnesses that cause hospitalization or severe disability and eventually death are in the elderly, because most of our deaths are in the elderly now. We can be grateful for that. That's something that's happened over the last 100 years. We can come back to that. But those diseases take decades to develop from lifestyle and risk factors in one's diet, exercise habits, smoking, drinking, sexual habits, which are then grafted by Mother Nature onto your genetic inheritance that you get from your parents. And the combination of these leads to conditions like heart disease, chronic lung disease, emphysema, bronchitis, the cancers, many, many kinds of cancer, and type 2 diabetes. So just as an example, about 90% of type 2, which is adult onset diabetes, is directly related to how heavy you are. So even though you might not be very heavy compared to other people, if your particular genetic profile is that you can't carry that weight and manage it, you will get to type 2 diabetes. And we now know it could be reversed if we put you on an 800 calorie diet for a few months, which is very severe, called the Newcastle diet, and then follow that up with indefinite calorie reduction. Exercise helps. So what I'm saying is people have this kind of magical view that medical care will save them when, in fact, it's them themselves that could save themselves because they needed from a much earlier age to take their health seriously. And your ability to do that is a function of how much education you have, how solid your income and your self-image is, how much confidence you have in tackling challenges in your personal life. So, general terms, the people at the bottom of the social economic ladder don't do those things as well. And it's not because they don't want to or because they're not capable in an intellectual way. The real problem is that their lives are so full of chaos and other challenges that they don't ever get around to looking after some of those features of their life. So if you tell people that most of the diseases that cause disability and death in our society now, which we die of an advanced age, are generated by those kinds of exposures, they're a bit surprised. Mm-hmm. They didn't think about it. And if you want to prevent those things, you have to start by the time you're in middle life. You can't leave it until you're 60 or 70 and you've got the disease to reverse it. You've got to change the way you live by age 40 or 50.
So, so you still believe in the social determinants of health?
Yes.
Is that right?
I teach them and give them as part of my advice to governments when I'm asked, which is not infrequently.
And there are many other researchers like you and many people who are in those high-powered decision-making jobs that believe in the social determinants of health. Okay. So if they've been around for decades and they have been implemented in health policies, why is it that we have seen such little change, such little improvement in health inequities, generally speaking? Yeah,
well, there's no question that the differences in health between the rich and the poor, the educated and uneducated, have not grown any less. Certainly in Scotland, they've been kept very steep differences, and the steepest in Western Europe. And they go back probably hundreds of years. We can come back to that if you like. There are two factors here. One is that there's an enormous system of machinery in terms of hospitals, physicians, labs. All of this system is set up to look after us after we're already sick. It's not particularly oriented to prevention, and it rarely gets the chance to do much prevention, although family doctors do their best, a job I did for more than 20 years of my life on and off. But they're always responding to symptoms, and the symptoms mean you're already sick. So that means that the illness care system is not incentivized to look upstream, as we say in public health, and think about how it could prevent problems from developing in the first place. The second reason that we haven't got on top of these ideas and implemented them is that they would require public health thinking to, I'm going to use the word infect in the positive sense, to get into the minds of people in other sectors who control those determinants of health. So, for example, I'm currently discussing with a non-governmental voluntary agency in Scotland and UK, giving them some advice about gambling controls and how to reduce the harm from gambling. The UK has one of the worst proportions of its population who are in poverty because of gambling addiction of any country. But the reason that nothing's been done about it is that it's an extremely profitable industry. And every community, particularly the poorest communities, has shops on the high street, we call the main street, for gambling. And a little place that might have only a few thousand people might have 3 or 4 different competing big companies that sell different forms of gambling opportunities. So, and the government makes its own cut because it's taxed. So there is not only a long tradition in the British culture of gambling, but there is a very profitable living to be made. from being in that business. So who's incentivized to control it? Not many people. So you can see how there are parallels in, say, the provision of high energy fast foods. There are parallels in tobacco marketing, parallels in alcohol marketing, you can see how there are many vested interests which make it difficult for the message about determinants of health to get through. And most voters in Western democracies, they tend to think that poor people are the authors of their own destiny. They think, well, if they'd tried harder, if they'd worked harder, if they'd studied longer, if they'd finished school, if they hadn't married badly, if they hadn't, had bad habits, that's a predominant view. But what you learn when you start to study it is that actually the price you pay to grow up poor as a child stays with you most of your life.
Given all the decades that you've spent in public health, and you've probably worked in every area of the social determinants of health, probably just about every area you've touched on and worked maybe more heavily in one area than another. Mm-hmm. And then you talk about the challenges, the huge challenges that societies face in implementing policies, that can help people with health inequities. Mm-hmm. If you were to look at, any one area of the social determinants of health, what have you concluded as far as what makes the biggest difference to people's health?
I think the biggest difference would be very high quality preschool education programs within walking distance of everybody's home, led by people who have a university degree in early childhood education, not what we have here. And also in much of Canada, what we have daycare, which scrabbles together people usually paid on minimum wage. The person who's the head of the daycare may have an early child education or development certificate, but most of the workers are minimum wage workers, don't have much training, and they're providing mostly custodial care in many of these environments, certainly in Scotland. There's not the opportunity taken to spend more time to improve the vocabulary, language expression skills, language comprehension skills, interpersonal skills, self-confidence, ability to deal with authority figures that could be and should be done to level the playing field of life for those, as they say in Scotland, weans, meaning wee ones, who come from disadvantaged families. And if you don't start that with disadvantaged children, by the time they're 2 or certainly 2, maybe even 1, if they're in a very unstimulating family, then you've lost some of the opportunity to put in place the optimal wiring in their brain, because the brain's wiring is proceeding at pace and is largely, most of it, completed after three or so years of life. So you've got to get in there and stimulate those little kids. And the only way you're going to do it is by having an inviting, free, high quality early childhood education and development center in every neighborhood. So where is that happening? Holland, Norway, Denmark, Estonia. Now you'll notice those are all northern and northwestern European countries. And that is to do with a long, long process of their deciding years and years ago that was the best investment they could make to reduce lifelong poverty and underachievement. And in fact, those societies are relatively successful in reducing inequalities later in life, socioeconomic to start with, inequalities, but health inequalities. They tend to be. And just to give you a kind of a surprising outcome of this, the tallest people in the world today are Norwegians and Dutch. And most experts think it's only partly because they have the genetic potential, because genetically they had the potential, but they didn't reach it in prior generations because of disease and poor nutrition. And, they went through some terrible things in World War II, the Dutch famine and all the rest of it. But the point I'm making is when you give everybody a good, solid start in childhood by the kinds of early care development centers I've described, then you automatically level up the children who are less advantaged. And part and parcel of it is that everybody reaches their potential, and height is just one marker. Height is just one marker of that.
Mm-hmm. What is there one message that you would like to leave with people about how they can, sort of have hope for the future and to improve the situation about health inequities and to create a more equitable society for people? I mean, when people listen to this, I think they do feel helpless. They feel, well, my goodness, what can I do?
Well, I think the key thing is that there's a great positive message in the nature of human potential. Probably less than 1 in 10, maybe less than 1 in 20 babies born in a wealthy society in the world are damaged in any way that will interfere with their life chances. So 90 to 95% of babies born are capable of reaching remarkable accomplishments, achieving them in a lifetime, whether they end up as musicians or poets or engineers or astronauts or any of the other walks of life. Both sexes, people of all gender persuasions, let alone, of course, all people of all racial and ethnic backgrounds. So that's because biologically we've achieved healthy babies, pretty much. We still have a problem with premature babies and some rarer children with congenital abnormalities and actual learning disorders. So those are important to care for and take proper educational policies and put them forward to deal with those special cases. But they're not a very large fraction of each birth cohort of babies. So Mother Nature has now brought us to the point in life, unlike Tanzania, where I lived and worked, where a large fraction of babies are malnourished by the age of 2, 3. And there's damage going on. They don't get full cerebral development because of it. And they have recurrent infections for reasons we've already described. So they don't have the full potential to achieve societal goals for everybody, high levels of accomplishment and productivity that we do in the rich world. But we're squandering it because we're leaving, in Scotland's case, a national survey amongst native-born Scots of literacy and numeracy, ability to use numbers, basic ability, done just a decade ago, showed that 20% of native-born Scots were functionally illiterate or innumerate because they never got proper preschool and school. So that is a terrible millstone economically and socially around the country's neck. And you can't fix that quickly. You need to start and invest in each new cohort of babies in the ways I described earlier. So that's the good news. There's something that could be done simply because the biological potential is there in a way which wasn't true historically. So I hope that leaves people with a sense that there's politics is the art of the possible. Public health is the art of the possible.
Yeah, a good line to end off on. John, thank you for the work you do.
Pleasure.
And for sharing it with us. Thanks,
Pleasure.
John.
Thanks, Mary.
John Frank is the former director of the Scottish Collaboration for Public Health Research and Policy and a professor emeritus with the University of Edinburgh and the University of Toronto. If you'd like to know more about John Frank and his research and ideas, go to our show notes. And please follow us on Twitter, Instagram, and Facebook @CramIdeas. Thanks for joining us today. See you next time.